So, good evening, friends, colleagues. This is Dr. Dipak Dave, along with my colleague, Dr. Dhanasekar Raja. We are the education committee members for the ISHKS. Our president, Dr. Indrajit Sardar, is also with us here. And our secretary, Dr. Leo Joseph, our patron, Dr. Pachore sir, Dr. Kincha is also one of the uh, important executive board member of the ISHK. They're all joined for this academic program. Today we have two very eminent faculties from India. The first talk is by Professor Dr. Vijay Kumar, who is the professor at the All India Institute of Medical Science, Delhi. The name itself is sufficient. He is very well trained in AIIMS, and he also has got diploma in tissue banking from Singapore, and he was awarded the Commonwealth Fellowship for arthroplasty, trained in Oxford. And along with that, he has also got a very senior, experienced guy, and we'll be talking on the hip subject, followed by Dr. Rajesh Maniar, and we'll introduce him. He is a senior surgeon and the trustee from Mumbai. But at the moment, I welcome Dr. Vijay Kumar on behalf of the managing trustee, Dr. Vikram Shah, President Dr. Indrajit Sardar, my colleague Dr. Dhanasekar Raja, and our team members. I welcome you here at the ISHK teaching program, and we are honored to have you. And may I request you to share your screen and start your talk, please.
Good evening, sir. Good evening, everybody. I thank you for your kind words, and thanks Ish for giving me this opportunity. So, I think can you see my screen?
Yeah, we can see that. Yes.
Okay. So friends, today I'm going to talk about dual mobility total hip replacement. And this has been here for quite a long time and it's quite catching up in India. So we should know the nuances of this system of total hip replacement. Well, dual mobility total hip replacement basically implies, a standard femoral head which is inserted into a large polyethylene head, which in turn articulates with the metal shell. So in effect, it increases the femoral head diameter and thereby resulting in an increase in the jump distance. So this is somewhat, if you've done bipolar, you would know that the head snaps into a polyliner, and this is how it is. So that's a femoral head, a 22 or 28 mm head. It can be a metal head or a ceramic head. It is inserted into a liner corresponding to the vestibular cup which is being used. So there are different types of liner, and these are very large liners. So the difference of liner to the cup is around 6 to 8 mm. So you need to be careful snapping it in. So you usually hear a sound, a suction sort of sound, and once that is in, so this becomes a single construct which has a 22 or 28 mm head inside a poly liner, and it should be freely mobile like this. So the advantage that it gives is, so if you see now, so this is a standard 36 mm head articulating with a cup with the liner in, and it gives a fair bit of range of motion. However, if you're using a dual mobility liner, so this articulation here occurs at two planes. One is the inner plane or the smaller head articulating, moving within the poly in the normal range of motion, and then the larger head comes into force when it is extreme range of motion. So in effect gives you a very, very big diameter head, which increases the jump distance and decreases the chance of any dislocation, and also improves the range of motion. Well, coming to the history, so this is basically a French concept. It was brought about by Bousquet, Rambert, and Rio. They married the Charles low friction principle of a smaller femoral head, diameter femoral head, thereby resulting in a lesser wear, along with the Mecki-Farrar idea of using a very large diameter femoral head so as to have an enhanced implant stability. So there were 3 generations. The first generation was the initial ones, which was the initial dual mobility cup, which was made up of inox or titanium alloy or stainless steel, and it had fixation. You had to fix it with pegs into the ischium, ilium, as well as the pubis, and it had an alumina coating, and it never got osteointegrated. The second generation was the one in which there was some sort of hydroxyapatite coating, and you now had hooks and screws. But the contemporary dual mobility cup is the one in which is made up of a cobalt chrome alloy. It can be a press fit one, and it has a bilayer coating, which is basically a hydroxyapatite coating as well as a porous titanium coating for enhanced fixation or osteointegration. Again, coming to the principle, it's a smaller joint enclosed into a larger, second larger joint. So the smaller articulation is engaged into most activities of daily living, and it prevents high wear because it's a very small head. And the larger articulation of the polyliner is involved when the activities exceed the normal range of motion, thereby giving a increased jump distance, increased hip stability, as well as a range of motion. Now, this was the monoblock dual mobility which came in, which was the initial dual mobility, but now a modular dual mobility is also available, which is basically, now you need to distinguish between those. A monoblock had a cup in which a polyliner used to go in. A modular dual mobility is a standard cup in which you can put in screws, in which a metal liner goes in, and in that you have the bipolar articulation. So the modular dual mobility gives you an option of using the screws also. However, it decreases the effective head size, which is used the effective the liner size, so it is much smaller as compared to a monoblock dual mobility. The problem with dual mobility initially was that you used to have intraprosthetic dislocation. The earlier generations had as high as 2 to 4%, but the recent studies or the newer generations, the intraprosthetic dislocation has decreased markedly. But you need to know why it caused. What was the cause of these intraprosthetic dislocation? Intraprosthetic dislocation means that the smaller head got dislocated from the polyliner. So there was 3 types. The type 1 was in which the retention rim of the polyethylene liner wore off. The type 2 was that the polyliner did not move, or there was blocked articulation between the polyethylene liner and the metal cup because of arthrofibrosis or heterotropic ossification. And type 3 was that if the cup became loose because of aseptic loosening of the acetabular cup. So this was all called as the IPD, or the intraprosthetic dislocation. And important in this is that the wear which occurs in the third joint. So this was described by Maniar et al. He found that the dual mobility cups have a third joint, which is basically between the neck and the polyliner. And here the design modification has to be done. So they chamfered it so there is less impingement of the neck with the polyliner. The neck needs to be the femoral stem neck. If it is a polished one with no edges, they perform far better. And of course, the polyethylene also, improved over the years. So the chances of wear is less. So the retentive mechanism does not give way. And you need to protect the third joint of the dual mobility cup. And this is another publication from the French group from Maniar et al. So they found that, at around 9 years, if dual mobility was being done with a polished neck, the chances of IPD or intraprosthetic dislocation was 4.5%, which doubled if abrasive neck was used, and the similar results they got at a longer follow-up of around 14 or 15 years also. So in order to prevent IPD, the newer designs have, there's a sufficient coverage of the head so as to, have a larger intraprosthetic jump distance. There is chamfering at the areas where the polyliner would get into contact with the femoral cone, as well as the polyethylene nowadays is much better. The elasticity is much better, so that once the reduction is done, the plastic deformation is not much. Now coming to the most commonly used, the modular dual mobility liner, which are basically standard cups of titanium metal baked shells, in which have the ability to, you can even do a normal ceramic insert or a standard polyethylene insert, or you can use a modular dual mobility insert also. So these are the modular dual mobility liners. They are available from all the major manufacturers. All of them have a monoblock sort of dual mobility as well as a modular sort of dual mobility. So now one needs to remember that if you're using a modular dual mobility, you need to be careful of the jump distance. What is the jump distance? Jump distance is basically the translation distance AB required of the femoral, required by the femoral head to dislocate from the acetabular socket. And there's a calculation which has been given, and this jump distance is dependent not only on the abduction angle as well as anteversion angle, but also the radius of the femoral head, and also on the offset of the head. What is the femoral head offset? The offset is the distance between the femoral head center and the cup opening plane. So if the femoral head is inside the cup, it has a negative value. If it is outside the cup, the head center is outside the cup, it has a positive value. Now you need to understand this. The jump distance is inversely proportional to the offset. So if it's a positive offset, that means the femoral head center is outside the cup, the jump distance would decrease as compared to a femoral head center which remains inside the cup, which is a negative femoral head distance. So it has been seen as you increase the head size, the jump distance increases, and the jump distance of the various dual mobility cups which is available is different from different company. However, the best jump distance is by the monoblock dual mobility system, which is around 17.4 mm. And again, coming to the same point, with the monoblock dual mobility, one needs to remember the femoral head offset is always a negative value. That is DM, the monoblock dual mobility. So the head is always inside the cup, and the jump distance is very good, or it's large. On the other hand, a modular dual mobility, because there is a metal liner inside, usually the femoral head is outside the cup, the plane of opening of the cup. So the offset is usually positive and increases as the head size increases, so the jump distance decreases. And this has been seen in various studies also with the
in a regional hospital, and then presented to us 1.5 years later at this
17 mm to as large as 24 mm, giving you a great advantage with respect to
as a 2.5-year-old with a dislocation, and then to my great disappointment, seeing really a saddle-shaped femoral head,
the violet line, which you can see in this graph.
I certainly learned from.
Around 15.3 mm till around 56 mm cup size, but thereafter, because the offset has now become very large, so which decreases the femoral head jump distance. So here it doesn't give you that advantage, it plateaus off. So till around 56 mm, the modular dual mobility will give you a good jump distance, but beyond that it is not that good. As far as fixed bearing is concerned, if you see the blue line, so with the 28 mm, it's low jump distance, it increases with the 32 mm, with 36 mm, and again in cups which are more than 56 mm, it is close to that, the advantage which is being given by the modular dual mobility. So you need to remember this. But the biggest advantage of a modular dual mobility is because since the offset is high, the center of the femoral head is away from the cup or outside the periphery of the cup. Here the range of motion is much better because the impingement occurs at quite a later stage. So the oscillation angle and the total range of motion with the modular dual mobility is much better than a monoblock dual mobility of fixed bearing. And this has been proven by various other studies also, similar results. But the concerns with modular dual mobility is that, often if you have not seated the metal liner, it would mal-seat, so there is a chance of liner dissociation, and more than that, there is a chance that there might be corrosion, fretting, metal line release, and there is a potential for adverse metal reactions if the sitting has not been proper. And this has been seen by various authors that as high as 5 to 8 to 10% of the liners of MDM or the modular dual mobility, there is an issue with the seating, especially if you are a low volume MDM surgeon as compared to a high volume surgeon. However, no short-term clinical application has yet been seen with the liner mal-seating, and the incidence is more, if you are using screws. So you need to be careful, and if the acetabular component gets deformed, especially if you have under-reamed the acetabular component, and if you have not cleared the periphery. So, you need to be careful while sitting in this metal liners in modular dual mobility. And now, a 4-quadrant test has been, used by some authors, in which, Once you have impacted the liner, you use an impactor and strike the cup at all the 4 quadrants and see what is happening to the other quadrant. So whether the cup is not toggling or not. So you need to be very, very careful while using a modular dole mobility. So this is a short video. Here if you see cup has been put in, the screws are well seated inside, then you put in, you clear the periphery, and the periphery should be absolutely clear, no soft tissue, no bone should be around the periphery while sitting in the liner, the metal liner. And once you are pretty sure that there is nothing impinging and the liner is well seated, then you should use an impactor. Otherwise, if you impact it beforehand, the liner would squint and it will be very difficult to get it out also, and it would there would be a mal-seating. So once you have done it, then you impact the liner in. Then you have the instrument which is there in the set itself. So you strike some blows at all the 4 quadrants and see if the liner is not toggling from the contralateral quadrant. So if you strike in the inferior quadrant, the superior quadrant, see that it is not toggling on the other side of the quadrant. Once you are satisfied, then you give it another final blow, and this is how you seat a liner of a modular dole mobility. Although mal-seating has not yet, no articles have described any clinical consequences, but there is an issue with respect to metal ion levels in these patients in which the liner has been mal-seated, and now various authors, even meta-analysis, are available in which they have seen that the level of the cobalt and chromium is rising in patients who have got this modular dole mobility. This might be because of the impingement of the screws which have not been properly screwed in, or maybe because of the mal-seating, and one needs to be careful, and maybe it's a good idea to use a ceramic head in these patients if you're using a modular dole mobility. So what are the basic, when should you use a dole mobility? So if it's a primary total hip you're using, you should use in patients who have a high risk for dislocation. Patients who are elderly, who have got a neuromuscular disorder, who have had a prior hip surgery or a femoral neck fracture, obese patients, if you're doing it for a tumor, if you have a spinopelvic issues. Certain examples, so the classic indication in a failed fractured neck of femur where chance of dislocation is high, even in fresh fractured neck of femur where the chance of dislocation is high. Dole mobility is a big boon for us as patients who have got an intertrochanteric fracture. Here again, if the abductor mechanism you're not very confident, dole mobility is a good option, and there are results now in literature also that the outcomes are very good in this. Patients have got a prior hip surgery where you need to remove the hardware, where there is a chance that you might compromise the trochanter and the abductor mechanism. Here again, dole mobility really helps you out. Examples like these. Patients with post-acetabular fracture, you're not confident about the inclination or the version of your cup. Here again, dole mobility would be a real help. So same has been shown in literature. Patients who have got dysplasia, if you're using a very small cup, here again, patients with dysplasia where a small cup has been used, a 44 or 46 mm cup, 44 mm cup. Here again, you can put a dole mobility which will give you a larger side head as compared to a standard fixed bearing cup. Example of similar patient. However, it is still controversial whether to use it in young and active population. However, there are results that the revision rate at around 10 to 12 years is around 11% in younger patients less than 55 years of age. So this was a meta-systematic review in which they found that although the first generation dole mobility did not do good, the second and third generation have performed better, and the revision rate is around 3 to 4% in these patients. Study from India where dole mobility cup has been used in avascular necrosis of the femoral head. But my advice would be, if you are using dole mobility for these patients, try to use a monoblock dole mobility rather than a modular dole mobility. It's a very good option for patients who have got a proximal femur tumor of the proximal femur. Because you have to do extensive bone resection, especially you're doing a proximal femur replacement. Here it is a big advantage to use a dole mobility. Patients have got spine issues or stiff spine or a flat back deformity or spinopelvic issues. So here Again, dual mobility would really help you out. Patients have got 3 or more level of spinal fusion. It is a classic indication to use a dual mobility, even if a fusion level is of 1 or 2, but the patient is elderly, or in patients who got a hip fracture or neurological compromise here again. So it's another example of a dual mobility in one of these patients who had this was an angst patient which spinal deformity was first corrected. Thereafter, the hip also required a replacement and a dual mobility was used. It's a big advantage to use dual mobility in patients who have got neuromuscular disorders and cognitive dysfunction, especially in patients who have got poliomyelitis. So this was a neglected fracture of the proximal femur. Dual mobility was used along with the subtrochanteric shortening. Especially in revision total hip replacements also, where chance of dislocation is a little higher. So it is recommended that you can use a dual mobility, whether it's any type of defect. It can be used with the statics, and a lot of literature has now come with the use of dual mobility in revision. So certain examples. So especially if you're doing a revision for a dislocation, you should nowadays use a dual mobility in these patients. Another example of a dislocated bipolar, failed bipolar, in which dual mobility has been used. So this was a failed total hip replacement in which the center of rotation was restored and a dual mobility cup was also used because the trochanter and the abductors were not so good. Another patient who had a failed, revision with implants all over post-trauma. So again, a dual mobility was used, cemented within the cage along with the buttress augment. Another patient in which, we used a 3D printed implant, and in here again, it's very easy to use to use a dual mobility cup, which can be cemented inside the implant. So if there are systematic reviews as well, NMAs, network meta-analysis, and it has been found that the best implant of choice in this age, as far as revision post-dislocation is concerned, is a dual mobility total hip replacement. Results have been good both in primary total hip replacement and in revision also. Sometimes if you're only revising the cup side and not revising the femur side, so you can mate a femoral head along with the dual mobility, any sort of cup, so mix and match can also be done. The registry results also show that the usage of dual mobility has increased in the last 4 to 5 years. However, the results are not so good. The revision rate is slightly higher as compared to a standard fixed bearing implant. So, but again, it has been said because you are using dual mobility for higher risk patients, so you expect the results to be slightly inferior. So maybe it's not a good to use as a routine choice because although it gives you enhanced stability, reduced dislocation rate, and improved outcome. The long-term results are still to be seen as far as cost effectiveness, and one should remember that all dual mobility cups are not the same. So this is the slide that I went to SICOT this year in Belgrade. So there was a full session on dual mobility by the French surgeons. So they also say that it is a compromise. So especially because of the third joint, between the trunnion and the poly, and even in France, all dual mobility cups are not the same. So you should be careful if you are using the dual mobility. My advice you should use a monoblock dual mobility wherever possible, rather than a modular dual mobility. I thank you for your attention, and I would also like to invite you all to our annual joint replacement conference, which is this year on 25th to 27th July. I thank you for your attention.
Thank you, Vijay. Before we can see the questions on the chat box and Dr. Pachore comes in, my 2 questions to you. Do you think that vitamin E poly is going to be more beneficial?
Yes, sir. Yes, sir. Vitamin E poly will be beneficial with respect to the wear in the poly cup. So, that would be an advancement, and it would definitely take care of the intraprosthetic dislocation, which occurs. So the wear would be less. And I think more is if you're using a ceramic head with the vitamin E poly or any highly cross-linked poly, that would give you lesser wear, especially in younger patients.
I also recently came to know, you may be knowing better than me, that they are coming up with the titanium, the gold-plated, the metal liner.
Yes. So in fact, there is an oxinium liner also now. available so as to take care of this this issue of the metal ions which might be released because of the because of the fretting that might occur, because you are adding another articulation there. So that is there, that is definitely on the lines. Yes, sir.
But your strong advice that in a younger people, because you already shown about 11%
Yes.
failure rate, so just for sake of giving them movements and to make them happy that you will be able to do this and you will be able to that, this is not the indication in a younger group without any other problem. Is that correct?
Yes, sir. So you are absolutely right. So there is a specific indication for using a dual mobility. It should not be used for all. So because it has its own issues, which are now slowly coming up, and especially the modular dual mobility cup. So it doesn't give you that much advantage. A modular dual mobility cup, a monoblock cup still gives you some advantage, but a modular dual mobility cup would not give you that much advantage. And there are problems, anticipated problems. So down the line. So a standard, ceramic head on a poly liner would outlast dual mobility in the long run, I think so.
Vijay, this is Leo.
Yeah, hi Leo.
Hi, Vijay. Just a small question. I think the best results for dual in terms of long-term longevity, best results have been described for the original Bosque cup, which is just a simple metal shell with a HA coated metal shell, highly polished on the inside, with no modularity inside, right?
So the best results are for the monoblock dual mobility. That's the Bosque cup.
Bosque cup, yeah.
The monoblock dual mobility, which which has a press fit fixation and hydroxyapatite or a bilayer coating, and which gives you so you do not have any interface or any liner in metal liner inside. Yeah.
Then you have a couple of flanges, if that is an option as well, which you can use if you want some extra articular stabilization as well.
Yeah. So you have two flanges above, especially in a revision situation.
But no screw fixation.
No screw fixation. Yeah. So
you have a small peg which can go into the ischium, and you have two extra articular flanges which go above onto the ilium. So it was available for a short period in India by Plus Orthopaedics, Endo Plus. In the I think in the mid 2000s we had it, in the first decade of the 2000s.
Vijay,
we had it here.
Vijay, there is one question in the question box. Can you see?
No, I can't see. Where is the question box? Okay, so it would be in the chat.
So Pachure sir has asked a question: absent abductor, what is the role of dual mobility?
Okay.
In case of abductor deficiency, is there a role for dual mobility?
Yeah. So in case of abductor deficiency, dual mobility has a definite role. So there are only two options with respect to an absent abductor. Either you can use a constrained liner or you can use a dual mobility. So dual mobility along with reconstruction of abductor is a better option. You can use a constrained liner provided the cup is well fixed. So so if cup is not well fixed, or then a constrained liner would put a lot of forces on the cup, and it would come out. So there the dual mobility will score over. So if the abductor liner means abductor repair plus a dual mobility is a better option.
Is this a forgiving implant? Can you describe this? That because you are going to get a very high range of movements, but is it very important that your alignment of the component has to be precise?
The alignment has to be precise, because if your alignment is not precise or within the ballpark range, there would be impingement of the neck to the to one of the to the cup or the liner, and that would increase the wear rate also. So your alignment has to be within the ballpark. It cannot be very much off.
Yeah, I think this was a question by Dr. Pachure again. Dr. Indrajit, are you there on the line?
Yes, I am on the line.
Yes, can you please comment?
Comment is dual mobility is still not a great option in many cases where we have so much good total hip replacements. But in certain cases, especially, I'm still very cautious about its use in poliomyelitis. Even then, some of the abductor deficiency is there. It requires an abductor restoration together with this.
Yes, sir, you are absolutely right. That's what I also, pointed out that.
Yeah.
But there are now with polio that, there are a couple of papers in which they have, they have used it with polio. So if you are doing a hip replacement with polio, I think, it's an option there.
Yeah, but yes, yes, Dr. Pachore.
I think when there is a complete abductor deficiency, I think if you are going to repair, fine. If you are not going to repair, this doesn't work. It has to be a constrained manner.
Yes.
There is no other choice. There is no other choice.
Yes, sir.
And these dual mobility are they are not immune for a dislocation. So
no,
if
they
you
are
are
definitely not immune.
all other has to be there. This is just for the postgraduates, All the parameter has to be in your limit. Otherwise, this also will dislocate because this impingement phenomena will take place. And just to know the youngster postgraduate, if it dislocates, what will be your protocol?
So if it dislocates, one thing is that it's very difficult to reduce it. Close reduction is it's not possible at all. So dislocation also in a dual mobility, you need to know. Suppose so how do you assess that a dislocation has occurred? Sometimes the head is inside, so it is an eccentric sort of head that you are seeing on an X-ray, and the liner is outside. So that's an intraprosthetic dislocation. So you may even get a CT scan to see that, and there is a bubble sign which is seen. So you see a radiolucency bubble sort of thing there, and mostly it requires an open reduction. Means it's very difficult to reduce it in a closed manner. And trying it, suppose it's not an intraprosthetic dislocation, it's just a dislocation which has occurred. Then trying to reduce it in a closed manner might create an intraprosthetic dislocation. That's another mechanism of creating an intraprosthetic dislocation. So you need to be careful, and mostly it requires an open reduction.
Suppose the dual mobility has dislocated, and you think then your bailout situation will be constrained liner?
Yeah, so that's a good option in those, especially if your cup is well integrated, osteo-integrated, and the cup takes in a constrained liner. So that's an option there, definitely.
For the cup side, you said monoblock is the better option with all the reasons you explained. The fixation part, apart from the flanges, are there any other options which can?
So the fixation part is that most of them have got some pegs or flanges or grooves on the acetabular side, and they have got a so they describe fixation of these in three manners. One is the primary fixation using the press fit, then there's a secondary fixation which occurs because of the hydroxyapatite coating, and then there's a tertiary fixation because most of these cups, they say they are made of titanium, have a highly porous coated. So after the hydroxyapatite sort of absorbs or forms a bone, then again there is a there is an avenue for it to osseointegrate because of the titanium porosity there. So that is how it has been described. But so there is a cemented dual mobility also monoblock. So you can even cement although cementing in a metal back cup is not a great idea, but it is available, and that is the liner that we use usually in revisions. So we cement in the cemented dual mobility inside a tantalum or trabecular metal cup or a cage or a 3D printed implant. So if cementing is done properly in those, so they also have got a reasonable outcome. But those cups are separate, so you cannot. So that's a separate dual mobility cup, which is a cemented dual mobility cup, which comes in.
So in these cases where you describe with the 3D printing, so it's a 3D printing cup. You have cemented the liner.
They cemented the cup itself. Yeah. the dual mobility cup. So the cemented dual mobility cup comes in. So we cement that inside the 3D printed cup. So that's a monoblock cemented dual mobility cup.
Okay. Leo, any other?
We are okay. I think we are okay. It was a fantastic presentation.
Yes.
Thank you.
Thank you so much.
Patore?
Yeah, fine.
Very nice. Okay, Vijay, I
Thank
think
you,
we are on time, and thank you very much for sparing your time and coming on the teaching program. So thanks for your time and valuable and a very nice presentation. On behalf of everybody, our President Indrajit Sardar is here. So I take opportunity to thank you on behalf of Secretary Dr. Leo, my colleague Dr. Dhanasekar Raja, and all the other members of the ISHKS board. So thank you, Vijay.
Thank you, sir. Thank you, sir. I'm really grateful to the ISHKS for giving me this opportunity to present. Thank you very much.
Fine. Okay. Thank you. Our next speaker is very eminent senior arthroplasty knee specialist surgeon, Dr. Rajesh Maniar from Mumbai. He doesn't need introduction. Rajesh, have you shared your screen, or you would like to do that first?
So yeah, I will do it as soon as you think I can do that.
Yes.
Okay.
Yes.
So let me. How do I do that?
Vaibhav, are you there, or Poonam?
Yes, sir. I'm there.
Yeah.
Vaibhav, can you
you
help Dr. Rajesh, please?
Hi, sir. So there's an option called share right at the bottom.
I've gone into that. Now there are 3 screens: documents and advanced documents.
Yeah.
No, it says whiteboard.
Sir, sir, right in the middle on the bottom, there's something called share, no, sir?
Yeah, so I've clicked the share.
Yeah. In that, you will see a list of tabs which will show the kind of the exact slide that you want to the screen that you want to show.
Exact screen. This first option: screens, document, and advanced.
No, it's whiteboard tablets.
Press screen.
Screen.
You can share the entire screen.
1 minute. I think it is. Hello. Share.
And then you have a pop-up menu which has 3 tabs on the top: screens, documents, advanced.
Correct.
Press screens.
Yes.
And then you have multiple tabs of whatever is open in your computer right now. Or if it is only one tab which is open, that screen will be shown. You can choose that.
My PPT is open, but it is not showing up. Desktop 1, universal access.
So in the screen option, there's application windows, multiple windows you can see. In that, you can click on the PPT, which are there open.
That PPT is not showing up here.
Can you open the PPT first on your computer?
It is open. I can make the PPT. Start the. Okay, I've done that. Now again, I'll share. Open system setting. Allow Zoom Workplace to share your screen.
Yeah, allow.
I don't know what to do. Let me get 1 minute. Let me, my son, help me with that.
So your son is back from Canada.
Yes.
Give him my regards.
Yeah.
And my brother's regards. My brother is coming over tomorrow.
Is he?
Yeah.
Just here, Adit. Leo is on the line.
Hi, Adit.
Hi, hello, sir. How are you?
Fine, thank you.
So, no, not this one, but I'm not able to
Can you shut down and go to the Zoom?
Up to you. I'll have to quit this and reopen, okay?
Yep. Try it again.
So meanwhile, all those colleagues who have joined here, let us tell you about the upcoming Indian Society of Hip and Knee Surgeons annual meeting conference at the Mumbai on 4, 5, 6 April. We have excellent academic program prepared with some 9 international faculties. Some of them are professors from various countries, highly big names are there. We have a combined session of American Academy of Hip and Knee Surgeons, Italian Orthopaedic Society, and Indian ISHKS. So there's a combined session of these 3 associations. And we have tied up with the Italian Society this year. Up till now, we were having a combined session with American Academy of Hip and Knee Surgeons. And now we have another joint collaboration with the Italian Society. So it's a very big event. All the big national faculties, very senior eminent peoples are there. And we have tried to design a program which has got live in-box surgeries, multiple case presentations, symposia, discussions, and some talks. So we request all young surgeons to please register for this meeting. It is in the St. Regis Hotel in Mumbai, 4, 5, 6 April. And you can certainly register and take the benefit of this wonderful academic event. Rajesh, we can see your screen.
We can see your screen now, sir. You're muted. We can see your screen.
Okay.
Yeah.
Can you just move slide, Rajesh? One slide, can you move?
It's not going forward. Wait a minute.
1 second.
Yeah, it's
It is, yeah.
So, Rajesh, welcome on behalf of the Education Committee members, myself and Dhanasekar Raja, President Indrajit Sardar, Secretary Dr. Leo Joseph, our Managing Trustee Dr. Vikram, Patron Dr. Pachore sir, they're all here. And it's wonderful to have you on this platform. Friends, Rajesh has been a mentor for so many young surgeons and a very well-known figure in the knee arthroplasty in India and abroad. He has been the trustee of the ISHKS also. And as I said, he has trained many young surgeons under his fellowship programs. So he's going to speak on the rotating design in TKR, where it stands. So thank you, Rajesh, and may I request you to share your screen and talk.
Thank you very much, Deepak, and thank you all of you, Dhanasekar, Leo, Panchare sir, Vikram. I think you've been doing fabulous job. Unfortunately, I've not been able to talk earlier for some time, but today I'm very happy, and I'm going to talk on one other topic that has been close to me for a long time. So we really need to understand where do we stand with the rotating design in total knee arthroplasty. It's a subject which is really less understood because large number of joints that are done are fixed bearing, and I think that probably says it all. However, it has a special place, and that's what we need to understand today. Let me start by saying where I stand with the rotating platform today. We are currently in 2025 putting together my 20-year results for the study that I started in the year 2001 to 2003, my first 118 total knee with the rotating platform posterior stabilized knee that we published in Journal of Arthroplasty when we completed 5 years. We published again when we completed 10 years, and now we are submitting the 20-year results. We had 118 patients, of which 53 we've followed up currently. That is 70% of the people who are alive. That's very good at 20 years. I must say that 42 people have died, and of the remaining 70% have been followed up. The 30% which we've not been able to trace. We don't know whether they're alive, but we take it alive, and then 70% has been followed up. What we found is that all the patients that we could connect with, there is 100% survivorship of this posterior stabilized rotating platform at 20 years. No spin out, no osteolysis. Average age at the follow-up at the moment, naturally 84.2 years. So these are all very ranging from 70 to 99 at current age. And but they still retain good flexion. Function score is really poor because of the various other comorbidities. But so this is the paper which will come up soon. Oops. These are two other representative patients. Both had bilateral total knee 20 years back. The lady on the left, the other day, she said she climbed 15 stories when the lift didn't work in the hospital. She was visiting her husband. And excellent function. If you look at their 20-year X-rays, it looks pristine, as if the joints have been replaced currently. And that is what it is. The wear and tear on the mobile bearing is hardly any. And this is another lady, 21 years, bilateral LCS knee, 21 years. She's 93, still very active, and the joints function. She's from out of Bombay, and I couldn't get her X-rays, but she's alive and kicking, and so does both the knees. So where do we stand with rotating bearing today? I think it is being used for primary total knee. It is also being used for revision total knee, constrained implants, and most importantly, it is being used in the hinged total knee. In fact, rotating platform hinged knees are the only ones which have become really successful. You know, someone has said that life is lived forward, but it is understood backwards. And so also about many things in arthroplasty. And therefore, let us understand why the mobile bearing came into being, why we started using it. They were introduced way back in 1977. They are in its 5th decade of use and still continue to be used across the world. My experience has been with some of these design which have been most successful. LCS was the first rotating platform total knee which became successful. I used it from 91 to 2000, first 5 years in UK and then in India. This 55 cases were in India. And Sigma RP was the next, which I talked to you about the study from 2001. Sigma RPF as it came in 2005, high flex knee, and from 2014 till date, it is the Attune RP knees. In the revision, I've been using it from 2008, the constrained MBT mobile bearing tray with TC3 implants and the rotating hinge, SROM hinges and LPS, etc. now. Now, if we understand the history, the first successful knee implants were in 60s or early 1970 were total condylar all poly designs. they had a problem of high incidence of radiolucent lines and high incidence of loosening. Why was that? Because of the flexible plastic platform, when the load was being put on one side, there was uneven distribution to the interface or the bone. And therefore, to overcome that, the metal backing was provided so that the forces became relatively uniform. Now, the next stage in development was with the metal backing that came up was that whether to provide it as a monoblock, that means the metal and the plastic in one piece, or metal and plastic as two separate pieces. Now, monoblock designs were good, but there was a concern because the manufacturer needed to make too many sizes and too many implants. For each polyethylene size, they'll have to have a metal backed component attached to it, and that made it difficult, particularly as the knee evolved into right and left and multiple sizes. But it did give a very good results. However, the surgeon found another difficulty on the table of adjusting the polyethylene. If after implanting and releasing the tourniquet, if one wanted to go up and down the size, that was not possible. So the modular design became more popular, where plastic is separate component, which solved the manufacturer's problem, but it added another problem, and that was the problem of undersurface wear, because the locking between that plastic piece and the metal was not that secure as it could be done in the factory. And therefore, to reduce that, modular design evolved into two types of plastic bearings. One was fixed bearing, which had a locking mechanism, but relatively poor locking mechanism, and mobile bearing, which did not need a locking mechanism because it allowed the mobility. So the first people to design the mobile bearing total knee was from Oxford, Goodfellow and O'Connor in 1976. They did both the unicondylar knees, which we are still using in their second and third and fourth generation, and a total knee as well. However, their total knee didn't really become successful. In 1978, Beacle and Papas designed LCS knee, again a rotating platform knee. They designed unicondylar as well and a total knee as well. Their total knee became popular. The total knee they designed in two different. They found a meniscal bearing one, where you can retain both cruciates or only posterior cruciate. And when you sacrifice both, they designed a rotating platform, which is what we are talking about. My experience has been with rotating platform, and by and large, it is that design that has become successful in the world, not the meniscal bearing with cruciate retaining. I don't think they are being used at all, but I saw them being used when I was in England. Quite tricky and erratic results. Now, so both these designers claimed that there was better knee kinematics when you had a rotating platform or the mobile bearings, because they share load with the surrounding soft tissue. The knee is designed to do that. Now, there's one other thing that we need to understand about mobile bearing, that you can have a movement of the bearing only in one direction. That means either rotation or front to back or side to side. That is single direction. Or you could have a bearing which can go in multiple direction at the same time. That means it can rotate, it can go front to back. These are multi-directional, and I put that in red because it is the multi-directional mobile bearings that have failed, because it has wear rate which is really high because of the multi-directional movements. So again, we are narrowing it down to the mobile bearing. It is the unidirectional rotating platform knees that became successful over the years. And why did it become? Because the the contact stress limits for the polyethylene is 10 megapascals in the industry. In the human, this thing, it should be even further less. Let us say 5 megapascals. And it is, you to reduce that much amount of contact stress, you need to have larger amount of contact between the surfaces where the weight is being transmitted. Let us understand what is polyethylene wear. Polyethylene wear in total knee occurs at three places. One is the articular surface, that is where the femur and the plastic articulate, or the undersurface where the plastic and the tibia articulates. And the third, where the post, if you have a posterior stabilized knee, then you have a third area where the wear can occur, that is between the post and the femoral contact points. Now, if you look at this slide, if you have a small area of contact, the contact stresses are very high, 32 megapascals, which is way above the limit. And as you go on increasing the contact areas, you can see that the stresses come down, but they really come down when you have a large contact area, which is only possible with the rotating platform knees. So why you do not have the large contact area with a fixed bearing? And that is because there is a kinematic conflict. Say you have a larger contact area, as you can see here on the right side, then the contact stresses are going to be very low. However, what it does is that it introduces constraint. That means all the forces in the sliding or the medial lateral directions will be all transmitted to the fixation on the tibia, leading to high forces on the fixation. On the other hand, if you have a small area of contact, you have a high contact stress. There is low constraint. Of course, the fixation is preserved, but the plastic starts wearing. So there is a conflict here. But when you have a rotating platform knee, you can make two areas do separate movements. You have a good contact area at the femoroplastic articulation. Therefore, there is low contact stress. And now the other movements occur at between the plastic and the tibial articulation. And therefore, now you have a low constraint force also. So there is a kinematic agreement here. And I spoke to you that multidirectional mobile bearings didn't do well. So when you have that sort of a construct, it has been shown that the wear in retrieval analysis is extremely, extremely low. And this is shown in some of those early studies, the difference between the fixed bearing and the rotating platform. There is almost 7 times or even less wear in the rotating platform designs. And these are some of the plastics that I retrieved in my early practice. In few years, you can see wear and tear on the fixed bearing on your left, and the right, which has been retrieved after many years of use, still has no wear and tear at all. So the second wear and tear that occurs is between the tibial liner and the tibial base plate. That is the undersurface wear. And that really was the biggest problem in the decade between 2000 and 2010. And you can see here that the locking mechanism is actually never very foolproof to begin with, because all studies have shown that even when you lock it on the table, there is some micro motion going on at the undersurface. But over the period of years, when you use it, the locking mechanism starts failing. And here at 7 years, you can see how much movement this particular bearing has at the undersurface. Now that's enough to generate so many polyethylene particles that you start getting osteolysis. And that is what happened in just about 5, 10, 15 years after the fixed bearing, around about that time between 2000 and 2010. And this is various studies showing that the undersurface wear leading to osteolysis. All these studies showed that. There was a study which from Dr. Ranawat's center came, Jose Rodriguez published it at 7 years, that there was no osteolysis if there was all poly implant, because there is no undersurface, whereas metalback modular 6 knees had undersurface wear. Now, we would think, why would there is no undersurface wear in the rotating platform knee? Because there is an undersurface there as well. Now, in that initial design where the fixed bearings were made from titanium to improve the locking, the rotating platform were made from chromium cobalt, which could be polished to a very high degree. And therefore, the undersurface had a very smooth surface to rub on, and therefore the wear and tear was less. But apart from that, the most important reason was that there was a 100% contact at the undersurface, and there was a unidirectional movement. We'll probably come to that in a minute, why that is so. The studies that showed the survivorship with the LCS RP knee at 10 to 20 years was in the range of 91 to 100%. And in fact, most of them showed that there was hardly any osteolysis. So it is the lesser articular surface wear, lesser undersurface wear, better kinematics, and excellent long-term results that increase the interest in rotating platform implants in the roundabout turn of the century. And there was a tremendous development of the rotating platform implant from all the different companies. And these are various companies who made it, and there are many more that came after that. I looked at my results with the LCS because in 95, when I started my practice, that was the only rotating platform knee available. And I implanted them in 55 knees. It does not have a post. It sacrifices posterior cruciate. And therefore, in severely deformed knees, you can't put it. You really need a very, very stable knee. And I kept a detailed record, the pre-op and post-op scores and the intra-op surgical detail. And we published the 15-year results in Indian Journal of Orthopaedics in 2013 with 98% survivorship at 12.5, average 12.5 years, minimum 10. There was no osteolysis in single patient. However, the downside was that the average range of movement was 101 degrees. We really needed to be tight in these patients because we didn't want any sublux or disloc to occur. The scores improved tremendously, but the average movement was 105 degrees, which certainly for our population, we would want more. But I selected the prosthesis for young, active, and heavy patients where I was wanting to have this prosthesis go into the second and third decades. Here is one such lady. This lady was 135 kilograms when I did. And these are the 17-year X-rays. She is from out of India. She's currently 23 years post-surgery and she's still going on, but I am unable to get her X-rays because she's not visiting here. But the knees are surviving. She sent me her 20-year X-rays. So those are good. The knees are still good. And you can see hardly any wear and tear on the plastic. And the patient who was 135 kilogram at the time when I did it. This is another very, very young lady. Bilateral LCS knees post-surgery, and these are at 18 years. Both the knees are still surviving. Yet another patient with rheumatoid arthritis, operated in 2000. It is more than 20 years now. The knee is still surviving, and you can see that not only the articulation is very pristine, you can see that there is no osteolysis anywhere. The prosthesis remain well fixed. So for me, what the rotating platform knee did was that it gave me better knee, better understanding of the knee kinematics. It gave me refined my technique for ligament balancing because it really needed to be very precise. It gave me confidence in treating younger and heavier patients and improved my technique of even fixed bearing knees. I started balancing them better and better. So with the LCS knee, one of the drawback was the spin out, because as I said, there was no post and both the cruciates were sacrificed. So the literature reported highest being with Burt, 11-12% dislocation rate, but all the other users started doing it, better balancing and using it in patients with a good balance. The dislocation rate went down. But to reduce this and to improve the range of movement, this rotating platform evolved into posterior stabilized rotating platform, where you now have a post to guide you to have a better range of movement and to reduce the incidence of spin out. So I wrote a rationale for the posterior stabilized rotating platform knee, explaining in this particular article in year 2006, on your left is the LCS, why did it evolve into the PFC sigma RP knee, which is on the right? So if we understand what was existing at the time when the LCS was being used was the fixed bearing posterior stabilized knee, as you can see here on the right, IB, PFC, and a few others. Both had over the decade of 2 to 3 years of use, and both were successful, but with different sets of results. What was good with the LCS RP was that there was a less articular surface wear, less undersurface wear. Post wear was less because, again, with the rotation, the bearing was rotating with the femur. Whereas the downside was that it did not have a very good range of movement as the other counterpart. The kinematics were not as good as far as the posterior rollback and the possibility of spin out. Now, these were exactly opposite with the posterior stabilized knee, that the wear was higher, but all the other things were better. And therefore, it just logically felt that both need to be combined to try and get you the best of both worlds. And that's exactly what happened. LCS was combined with PSFP design to create PSRP knees. And it was introduced in USA in 2000, and I started using it when introduced in India in 2001, the Sigma RP knee. And in the first 2 years, I did about 500 total knees, out of which 133 were PSRP designs. So all of those, I started a prospective study to go on for as long as I could. And we presented it's a consecutive series of first 133 knees, single surgeon, same technique, cemented and patellar resurfacing in every patient. We collected Knee Society score, range of movement, outcome questionnaire, and radiographs at 3 months, 1 year, 5 year, 10 years, and now 20 years. We looked at the survival analysis. Here is one patient at 3 months. Excellent range of movement, because now the posterior stabilized knee had a better posterior rollback and the range of movement suddenly improved for my patients. And this is the first report at 5 to 8 years in Journal of Arthroplasty in the year 2011, with again 100% survivorship and a very excellent range of movement. Then at 10 years, these are some of the patients at 13 years with ability to bend the knees fully and be very, very functional. And this was published in, again, Journal of Arthroplasty in 2017, 10 to 13 year result. Again, 100% survivorship, no spin out, no osteolysis. The range of movement had slightly come down, but that's because of the aging population. Simultaneously, we had a paper from Dr. Ranawat's table for 10 year showing similar results, 97.7% survivorship at 10 year. For revision at any reason, 100% if revision was because for the mechanical failure. There were no mechanical failure, no spinouts and no osteolysis. And some of the studies looked at the range of movement between the posterior stabilized RP and the fixed bearing posterior stabilized, and now it was similar. Previously, LCS knee had a slightly lesser range of movement. Now the range of movement similar. Also, the spinout did not occur in almost every study. We still retained the large contact area, unidirectional movement, and the post wear was also addressed because the femur and the post both rotated together and there was no rotational wear on the post. Now, coming to why unidirectional movement does not lead to wear, it's because there is as you do the single direction movement, the ultra high molecular polyethylene particles orientates themselves in a principal direction of sliding. That increases the strength in the direction of the movement of the fibers, and therefore the wear and tear goes down. And thus unidirectional movement is important. Here you can see as you have a unidirectional movement, the wear and tear is very little. As you have multidirectional movement on the plastic, the wear and tear goes really high. And these are some of the designs with multidirectional movement, and they have shown high wear rate. This is the monodirectional rotating platform knee. I stress again, it is the monodirectional rotating platform knee that has shown the better results. So now I must mention here, and this is a very important slide because this is where we stand with it today. The LCS RP evolved into posterior stabilized RP to improve the range of movement and stability into high flex further. But as that was occurring, the fixed bearing also improved. They realized that the locking mechanism needs to be better to prevent the undersurface wear. Tibial finish was improved. The poly itself was improved to try and reduce the wear and tear. And this is you can see that the wear and tear, which was so high with GVF, suddenly came down with crosslink. And when you have a better locking mechanism in chromium cobalt, it further came down. But it still remains higher than rotating platform knee. However, significantly lower to what it used to be about 20 years back. And I would consider that in current use, the wear and tear with the fixed bearing has come further down. So that all the issues that we were seeing with the fixed bearing knee with wear and tear and osteolysis and loosening in the first decade or beginning of the second decade have now been pushed, I would think, to the end of second or third decade. So it has tremendously improved, and I think that probably has made the rotating platform probably less popular in the primary knee because the fixed bearing themselves have improved tremendously. So this is another study where Dr. Ranawat looked at MRI at 10 years to assess the synovitis quantitatively in a knee. And they looked at fixed bearing, all poly and RP. And what they found that there was a significantly higher synovitis in fixed bearing and all poly compared to the rotating platform. And you can see here, this is my patient. One side I have done a fixed bearing on the left, 15 years. On the right, it is rotating platform knee, PSRP. And you can see at the time of follow-up, I can see that there is no synovitis on the right knee. Nothing. The knee looks quiet and pristine. The left has a significant amount of effusion in the knee, which is synovitis. It's still not failed. Patient didn't have anything else, but there is synovitis going on in the knee. And that's what Dr. Ranawat was looking at. This is another meta-analysis which looked at the TKS survival LCS knee on one side, 29 reports from all around the world. Surgeries done between 81 and 2005, and all other knees on the other side from Swedish Knee Registry. And what they found is that the survival rate was significantly higher on the LCS RP knee. So really, this was the main issue in the decade earlier, that there was a high incidence of osteolysis, which led to such a bone destruction when you took the implant out and needed a revision surgery. So if you wanted to avoid that, you needed to use rotating platform knee. And if you have patients, which many of us are patients, want to do high performance during their life after total knee replacement, such as dancing, sporting activity, yoga, then you really need a bearing which is going to have least wear and tear. So these are the patients where I really select the rotating platform knee. This further evolved into high flex knees. We all know that high flex design doesn't bring the further flexion, but it just makes it safer because the contact area is increased in that terminal flexion, and you can allow the patient to do this sort of activity if they want to, with a lot of freedom and confidence. So we published the reports of that at 2 to 6 years, high flex rotating platform knee, again in Journal of Arthroplasty, with very good outcome. And we've published the same group again at 10 to 14 years, 3 years back in Indian Journal of Orthopaedics with 100% survivorship. An excellent range of movement up to 150 degrees. And again, this patient had in 2022, average age was almost 80 years. We also published in journal comparing the range of movement between the three rotating platform, LCS, PSRP and high flex RP. And what we found that high flex and PSRP both had equal amount of flexion, but both had significantly more range of movement compared to LCS. And this has further developed into Attune RP. Now this is the implant I currently used. 2014 onwards, I've done about 500 plus by now. This is at 1 year, one such patient. Another patient with excellent range of movement and better patellofemoral kinematics. And we published the patellofemoral outcome between Attune and Sigma RP in the CIOS 3-4 years back. In that particular 75 matched pair analysis, the incidence of patellofemoral crepitus or pain was equal at 1 year. It was little more at 3 months with Sigma, but at 1 year it was equal. So although there are currently a lot of rotating platform implants are in market, the one which has had the longest track record and the ones which are most commonly used are from Debut. LCS is still being used in the world, and the copy of that, the Beacle Papas, the original designer has designed another one, Beacle and Papas. That knee is being used, PFC Sigma RP and Attune RP. Now, what I really want to talk about is the second part, which is where the rotating platform really makes sense today, and that is in the revision total knee arthroplasty. I've been using it from 2008, and I will open another PPT to talk about that. I'm sure I'll be able to talk for next 10 minutes, Dr. Dave.
Yeah, should be fine. We finish about 8:30 usually. So
Yes.
just give us some time to ask the questions.
All right. Let me just go through this very quickly, because I think in today's current setting, the most important use of rotating platform is in the revision arthroplasty, and I'll tell you why. We all know that. Sorry.
Yeah, fine.
So we know that the revision incidence is increasing in the world, and it is projected that it will go up and up, both in knee and hip. So why use mobile bearing in revision? Because of the success of rotating platform in the primary total knee and the hinge knees. We know that the primary knees failed in year 2002 because of the polyethylene wear and loosening. Over the years, the polyethylene wear has started coming down because of the better things that I spoke to you, but the loosening still remains higher because of the forces that are transmitted to the fixation. And we know that with the rotating platform, mobility neutralizes the forces on the fixation and therefore reduces the chances of loosening. On the other hand, if you look at the rotating hinge, the first generations really failed miserably.
Is your screen on? Because we are not able to see your PPT.
Oh, you're not. 1 minute. So I need to share that again, probably. Okay. Okay. Are you able to see it now?
Yes.
No, this is
yes.
This one, no? No, revision.
Yeah, revision arthroplasty. This is revision.
Yeah. Okay. So sorry about that. Okay, so the incidence is going up. Why use it? Because of the success that I told you. And polyethylene wear is the main reason, but now it is mainly the loosening. And the loosening in mobile bearing will be less because of the protection of the fixation. And that's what we've seen. The fixed hinges failed miserably because they became loose very quickly. Whereas the rotating hinge, which is the second generation hinge, didn't fail much because of the forces which were transmitted on the joint were neutralized, and therefore the fixation was protected. And Sardar reported the equal clinical outcome in terms of KSA score and the range of movement between posterior stabilized, condylar constraint, and the rotating hinges. So all that led to the satisfaction was highest with the rotating hinges. So all that led to the development of the revision total knee using mobile bearing. Also, on the other hand, if you look at the outcomes of the fixed bearing revision knees, there were two issues. One, there was high incidence of re-revisions. And if you look at the reason for the re-revision, first the incidence at 5 years, 15% re-revision rate with fixed bearing, 20% in just 8 or 9 years. And not only from one study, from different areas, Korea, from Europe, everywhere similar results. And the main reason for re-revision was aseptic loosening. That means the implant fixation was failing for some reason. And this video will show you why. When you have a fixed bearing and you have as you flex and extension, whatever forces you have, which are transmitted to the fixed plastic, it'll be transmitted to the fixation area on the implant. And what then happens is that the implant starts wobbling into the fixation area, and that leads to loosening. You can see here that the tibia with each movement is showing and over the period of time, that leads to loosening of the implant. And this is shown in some of the patients that I have revised over the time. You can see that the fixation is loosening out here around the stem. Here the stem is cutting out. Here the stem itself got broken because the surgeon had cemented the whole length of the stem. Now, this does not occur with the rotating platform because, as you can see here, as the femur moves and rotates, the rotating platform rotates along with it so that the fixation is protected. And this sort of a movement continues to occur. This has been shown in the in vivo kinematics. Dr. Komistek, my friend, allowed me this slide, and you can see as the knee flexes completely, you can see the plastic rotating along with the femur. So this is why the MBT in the constrained form in revision was introduced in the year 2008, and I started using it. I've used it in more than 100 patients now. Most of them in revision, some in the complex primary situation, and many of them have completed it 10 years. Various indications, good clinical outcome after the operation, range of movement also excellent. Most important slide, re-revisions, infected cases. I had 1 re-infection and revised out of 32, 3 needed lavage and liner exchange. 2 patients who died had a functioning implant at more than 5 years, but no patient had aseptic loosening. No patient had lavage and liner exchange in the aseptic loosening cases. More than 5 years, 2 people again died, unrelated causes. So there were no mechanical failure in this 77 patients who have finished 10 years. So some case example, UKR revised to this is not even constrained mobile bearing platform. 10 years post-surgery, good function and mobility. Another patient had a bilateral total knee elsewhere and had infection on both sides. Both had first stage and then revised at second stage separately with mobile bearing constrained total knee arthroplasty. An excellent function in just 1 year for both sides. Another patient, supracondylar fracture, first fixation failed, second fixation, infection, revised to a mobile bearing implant, very heavy patient, this is 6 years, remains in good function. This patient, one of my patients, 2001, I did a total knee fixed bearing. In just 9 years, she had osteolysis. You can see that osteolysis. So I revised in 2009 to a mobile bearing constrained device 2009. This is at 10 years, 2019. Today it is 16 years. The knee is still absolutely functional and there is no evidence of any wear and tear. This patient who had a total knee had a mycobacterial infection, 2-stage revision. After the first stage, when she came, there was still a discharging sinus. So I repeated the first stage. And then I realized that the bone had really cracked into a second condyle as well. And therefore I did a distal femur replacement. Again, it is a rotating platform plastic, even in a young patient. And this is her couple of years after the operation, absolutely functional. And because of the nature of the rotating platform, I would expect in such a young person to have a long-term results. Another patient where multiple 7 surgeries, ultimately I did a rotating platform revision in the knee, full femur replacement and a total hip, and the patient who was extremely multiple discharging sinus in the bed has started mobilizing. Of course, with a shortening, tremendous shortening, but she's back walking about. So I think in summary about the mobile bearing revision, unidirectional movement, remember, it decreases wear. Rotation decreases the pressure on the post and therefore it protects the fixation and therefore it reduces the chances of loosening after revision surgery. That is the key. I've been using it for more than 16 years with excellent results and there have been no mechanical failures, with some patients achieving excellent range of movement as you can see here. I think we would stop there and take some questions. It is 8:30, I know, but if you think we can take, I would be happy to answer.
Yeah. I think we will take some questions with Dr. Rajesh. Thank you very much for this excellent talk. Before somebody comes on the chat box, my question to you, yes. We all have an apprehension that obese patients and rheumatoid patients, we should go for a fixed bearing. You showed us some good results. Yes. So my next point is in a severe deformity like FFD or a mild recurvatum, severe varus, would you go for RP?
Right. So I think on the blanket, no. But in my papers which I published in Journal of Arthroplasty, I've mentioned how do I decide whether this patient should have an RP or not. I decided at the stage of trialing. If I find that the stability in extension as well as in flexion, medial and lateral imbalance is no more than 1 or 2 degrees, or when I do a little rotational movement, there is no subluxation of the plastic on either side, medial or lateral, then I would use an RP knee. So today I would not say there are some significantly varus patients where I don't have to do much releases, I still use RP knee. So it really depends on the trialing stage whether there is a good stability or not. Now, the stability is also less important when you're using constraint, like a TC3 or something. You have a higher post and a deep dish. So that means the stability, even little lesser stability, I would still use a mobile bearing. Now, in terms of the obese and RA, who are sometimes young people, I actually want to use rotating platform because I really want them to have no wear over the long period and protect their fixation. So they were really the key people I used to take all the trouble and put the rotating platform knee.
Dr. Pachore sir has asked a question there in the chat box. Can you see, Rajesh? Okay, let me read for you.
Yes, please.
If all these knees are done with navigation?
From 2004 onwards, all the knees I'm doing are navigation, but the study 20 years results I'm publishing, or the other results that I published earlier were done manually. 2001 to 2003 were manual cases.
Right. As you said that you decide on table sometimes. Now we have an option like in Attune to go for a fixed bearing and RP just at the last minute.
Yes.
So do you think that will make any, is there a result between Attune FB and RP in the literature? What is their own assessment?
So the difference in the wear and tear, you mean?
Yes, wear and tear and movements both.
Yeah. So I think clinically, no studies have shown that there is a better range of movement with the rotating platform or the fixed bearing in a primary knee setting. Revision setting, yes, but not in a primary setting. With a rotating hinge, it has been shown that it has a better stability and better movement. But in a primary setting, that has not been shown. But yes, in terms of the wear and tear, there is definitely a better contact, better racing, and the wear and tear is less. Now, whether that translates into a failure, probably with the better locking mechanism and better plastic with vitamin E or antioxidant plastics, I think that wear and tear will show up not in the first decade as it used to, maybe end of the second decade or even the third decade it might show up.
There is another question in the chat box.
I'm not able to.
Yeah, anyway, let me read you.
Yes,
is there a question answer upstairs you can see?
Yes, in your 135 kilogram, you haven't used the stem. You don't use in both fixed and mobile bearing or only in mobile bearing knees. Right. So I think, that case was done in 97 or 2000 in that time. So we have that understanding that in heavy patients, you would put a little stem. Today, we most of the time like to put a stem. However, the mobile bearing knees were not available with a stem. And things need to protect the fixation as much as the fixed bearing. Never seen with a heavy patient with a mobile bearing implant that there is a failure that you would see with a heavy. So I even today, I wouldn't worry in a heavy patient putting provided that you have good quality bone. That is primary. I say that. If you have a patient with a poor quality of bone, I think I would not put a mobile bearing. I would rather put a fixed bearing. Because early failure is a bigger problem than a late failure.
Dr. Leo, would you take over? Leo? He's not there. So, I think we can't see any questions there. Dr. Indrajit, Dr. Leo, Dr. Pachore.
Yes, sir. There is a question for you. Have you answered? Sorry,
Leo, can you
Yeah.
later on sum up, because I might lose my
Sure.
signals.
Sure.
The next meeting is 15th of March. I'm there only, but you can take over, please.
Yeah. I just had to go for a couple of minutes, sir, but I just wanted to know, have you answered the question that's come up for you?
Yes, I did. This 135 kilogram patient.
Yeah, you did. All right. Okay. So there's another question for you that I might have.
Okay.
So between which would be the best idea of minimizing backside wear? Highly polishing the tibial tray and constraining the poly insert in the tibial tray, or highly polishing the tibial tray and encouraging mobilization, unidirectional movement as we call it here.
Yeah, I think without doubt, it is the highly polished surface with allowing the unidirectional movement, because not only it will reduce the wear and tear, but it will also reduce the forces that are being transmitted to the fixation. It will also reduce the forces that are being transmitted to the post, leading to the post wear. And so I think there is little doubt that the way to go is to allow the mobility of the plastic by design. And the mobility should not be, it doesn't have to be fully going 360 degrees. The human knee, the mobility that you have is 11 degrees on either side. What is happening in the human knee is that the meniscal bearing is allowing you the tibia and the femur are not completely congruent. They are made congruent because of the two menisci, and they increase the depth of contact as well. So it's making both, allowing the mobility and increasing the contact.
All right. Thank you so much. I think Deepak sir is kind of traveling and we may be losing his signal. So there is another question for you.
Yes.
So is there a better outcome in mobile bearing compared to fixed bearing at early follow-up?
So in terms of what? Are you asking in terms of survival?
I think you kind of answered the question in your presentation itself. Probably in terms of function, that would be, because if it is going to be early follow-up, it has got to be function. So
I think the function, most of the studies have shown that there is no big difference. There are sporadic studies. Some of them have shown that there is a better deep knee flexion in when you load the knee. When you load the knee, you will have a better knee flexion because of the posterior stabilized rotating platform knees that are being used in many other rotating platform knees. But there is one study from France, Parka, has shown that there is better gait kinematics, but those are not universally shown. So basically, the function as we evaluate today is probably the same in both. No, so in my study, the study that we are reporting, we are only reporting the rotating platform knee. These are not the study where we have compared rotating platform with the fixed bearing. These are the first 133 knees of the PSRP type, and we wanted to report their function and their outcome. We've not compared them with the fixed bearing in our study.
And there's also another elephant in the room which we're not speaking about, which is the medial pivot, which is the latest kid on the block. So again, there is a slight differential difference in the concepts there between rotating platforms and the medial pivot. So which do you think? Rotating platform rotates from with a fulcrum in the center. So the medial pivot is a medial pivot. So between that, in kinematics, which do you think is better?
So kinematically, for the natural knee, the medial pivot is the right thing, because the rotating platform rotates right in the middle, which is not really the natural movement of the knee. Having said that, till now, we did not have any further mobility. What is important is to have the mobility. But I would think that the medial pivot knee is likely to gain more and more popularity for more than one reason. Not only that the pivoting is on the medial side, it also takes away this issue of a spin out or a worry of the instability. What sort of a stability you should have before you can put that is taken away from you, because it's ultimately a fixed bearing implant. Now, the problem with medial pivot is that we must understand this, that Like how all rotating platforms are different, all medial pivots are different too. The original medial pivot, the right knee, which became popular, had a complete congruency on the medial side. It was a ball and a socket joint. Most of the medial pivot designs out today are not that type. And therefore, each one will have to prove their own worth over the years, the survivorship, and whether there is any new problem added because of that. So it's not a completely congruent joint for most of the medial pivot knees today. Some of them have it. But it does allow you the basic principle of the rotating platform that you must have a mobility in some part of your knee to reduce the constraint forces, to reduce the forces on the fixation. That probably the medial pivot knee is going to provide. So it's somewhere in between with the amount of mobility that rotating platform allowed, and you still have a fixed bearing articulation.
So, and Rajesh, you're a very high volume surgeon. Now, in your practice, how do you decide which patient is going to have a rotating platform and which patient, or do you use rotating platform for all your patients?
All right. So yeah, that's the crux of the matter that you asked me, and this has changed over the years. Say 10 years back, I would have selected any patients who's heavy, very active or young. I would select that I want to put a rotating platform, because I will have less wear and tear. And this is the posterior stabilized rotating platform knee I would put. And I used to use it in about 40-45% of my patients. How I decide on the table. That means for every patient, I start off as if I want to put a rotating platform. Now I go through my steps of surgery. At the stage of trialing, when I look at my balancing, of course, I want to achieve my extension balance first, and then look at my flexion balance. If my flexion balance is very good, I can put the rotating platform knee. If my flexion balance is not good, either medially or laterally, there is a little sublux that is occurring as I rotate the knee in 90-degree flexion, then I don't want to put a rotating platform knee because I do not want to have an early failure because of the spin out. And I would rather use a fixed bearing knee. So in all the patients where I've had to do a medial collateral release using periosteum, superficial medial collateral release, even slightly, I would not use a rotating platform knee. I would use a fixed bearing knee. Similarly, if it was a valgus knee and I've had to do significant releases on the lateral posterior capsule or IT band, I don't want to put a rotating platform knee. I would put a fixed bearing knee. So my use was about 45%, 50% of the knees were mobile bearing, the rotating platform knees. But today things have changed. And in 2025, it has changed because the quality of the plastic, quality of fixed bearing locking mechanisms are tremendously better. So the failures that we were seeing in the year 2000 and 2005 or 10 in the first and early second decade in fixed bearing are no more seen today. And therefore, if somebody is 70, 75, or even little younger than that, I would not hesitate putting a fixed bearing. So my use of rotating platform today is probably 30-35% of my cases. For those two reasons, that if I have had to do the releases, if there is an instability, and earlier I really was very, very keen that somebody even in 60, 65 would have a rotating platform. But today I'm not so worried because the fixed bearings have improved.
As a corollary, you wouldn't really discuss which are the options you would discuss, do for the patient preoperatively, or would you give them the options, or would you say you would choose preoperatively?
I decide. But having said this, about revision, all the revisions I want to do a rotating platform revision. So I use MBT-TC3 for 80% of my patients. It's somewhere where I can't just get the balance right, or there are some other issues, I would use fixed bearing revisions. But otherwise, most of the revisions are rotating platform. 8% of the revisions are rotating platform. All hinges are rotating platform.
So I think there's maybe this may be the last question. This spin out nowadays don't occur because of controlled rotation of 45 degrees on both sides in buccal papas.
Yes, that is true. So the buccal papas have designed the knee with a post to prevent the spin out. And I don't know whether you're talking about buccal papas, because buccal papas also designed with a post and without the post. Their original LCS knee had no post. Both the cruciates sacrificed. It was a total condylar design. but then they went into designing posterior stabilized knee, and so the post will prevent, or they have a lock on the rotating itself. It will not allow more rotation, and therefore it will stop the. Completely agree to that.
And also buccal papas, you balance your flexion gap first.
That's right. With all LCS, etc., you balance your flexion gap first, and then you make your extension cut.
Yeah. So I think
Fred Beacle was the designer of LCS knee. Original LCS knees was designed by Fred Beacle and Papas, who was an engineer. And then they sold the patent to Depue. The LCS knee became Depue's, and Beacle designed a new knee, Beacle and Papas.
Okay.
It is similar to LCS, yeah.
Yeah. So I think Dipak sir is traveling, so he's kind of he may be out of range with regards to signal. So I think we've had a fantastic meeting. It is time to sum it up. We had two wonderful presentations by well-known surgeons in India, Professor Vijay Kumar from AIIMS and Dr. Rajesh Maniar, who's one among the high-volume surgeons in India with regards to knees. I should thank you, sir. Thank you so much for spending your time and your opportunity and to share with your huge experience with us. I should thank Vijay Kumar as well for his wonderful talk. And I'm sure this should have benefited a lot, all the people who listened to it today. Thank you so much.
Yeah,
Thank
I think
you
the
so
next
much.
meeting, Leo, is 15th
Yeah.
of March.
Yes,
15th of March.
Yes, sir. Yes, sir.
Thank you, Rajesh. Thank you.
Thank you so much. Thank you so much, sir.
Thank you.
Thanks.
Good
Thank you
night.
so much.
Okay. Fine. Thanks, Leo.
Thank you so much, sir. Thank you so much, sir.
Hey, Deepak, where are you
Thank you so
traveling?
much.
Deepak, where are you traveling?
He's out, sir. He's out.
Chalo.
He's out of signal already.
Okay, Leo.
Thank you so much, sir. Thank you so much.
Bye.
Sir. All right.
Either I leave the meeting.
Yes, sir.
Huh?